So in this topic, we will discuss about difficult spinal. Then we'll discuss different positions, that is sitting, lateral, and prone. We'll discuss about approaches, midline, paramedian, talus approach, and we'll also discuss the recent advances like USG guided spinal anesthesia and CARM guided spinal anesthesia. Next slide, please. So what is the difficult spine? What is the definition? It is an anticipated or unanticipated failure of introduction of the needle or failure of getting wet tap or free flow of CSF. There are multiple attempts at lumbar puncture with subsequent consequences or problems. So we can anticipate difficult spinal. For example, in case of obesity, if there is any spine deformities like hyposcoliosis, or whether if there is a previous spine surgery, or in case of elderly patients, we anticipate difficult spinal. Next slide. So how will you prevent this difficult spinal? By a preoperative assessment. We identify the difficult spine by asking the history. We ask about previous spine surgery. We ask about previous difficult or failed spinal block, or any family history of failed spinal block. Then we examine the spine of the patient to rule out any abnormalities of the spine. So the true difficult spine is truly difficult to manage. Next slide. So there is a one score, difficulty score for spinal anesthesia. The patient characteristics are used for this score, like which are familiar to the clinicians, like age of the patient, BMI of the patient, spinal bony landmarks, spinal bony deformity, radiological characteristics of lumbar vertebrae. So each these difficulty predictors are given the score 0, 1, 2, and 3. Then we'll do the summation of these difficulty predictors in that patient, and then this course is stratified into grades from 0 to 8. So grade 4, at or above which the score is, we can predict the difficulty in giving the spinal. Next slide. So finally, you know there is a difficulty in giving spinal anesthesia. So how will you manage this difficult spine or difficulty in spinal giving spinal? So you can give a different position to the patient, or you can use different approaches of the spinal, and you can use recent advances like USG guided or CARM guided. So first we will discuss about the positions. Three positions: sitting, lateral, and prone position. So first we'll see the sitting position. So already you know the how we give the position in sitting sitting. Patient should sit on the table with legs hanging over the side of the table, and the stool is feet is supported by the stool. The pillow is placed in the lap, so that the neck and arms are flexed to open up the lumbar vertebral space. So it has a lesser degree of difficulty. In this, the midline is properly maintained, and the landmarks are easier to locate. So sitting position is recommended for obese patients, saddle block anesthesia, in pregnant patients, or patients with abnormal spinal curvature. Next slide. Second position is lateral decubitus position. It is most common position, as shown in the diagram. The back should be parallel to the edge of the table, and thighs flexed over the abdomen, and neck should be neck also flexed, so that the forehead is close as possible to the thighs. Here in this lateral decubitus position, there is a less hypotension as compared to sitting position. The identification of anatomical landmark is difficult in lateral position. It is difficult in patients with fractures. So it is useful in bedridden patients, ICU patients, and in patients who cannot maintain the sitting position for long time. Next slide. Then third position is prone, that is also called a jackknife position. So here the patient should be in prone position with the OT table flexed under his flanks, just above the iliac crust. It is appropriate for rectal, perineal, or lumbar procedures where the position of surgery is same as that of the anesthesia. Next slide. Then we'll discuss about the approaches. Three common approaches: midline, paramedian, and the third is Taylor's approach. So midline is a technique of first choice. So what are the prerequisites for this midline approach? We should minimize the lumbar lordosis. Means we we flex the neck and arms of the patient to open up the lumbar vertebral space. And then we identify the L3, L4 interspace, which is at the level of highest point of the iliac crest. And then we identify the other subarachnoid space. And the paramedian, how will you approach? How will you give this paramedian spinal? We palpate the superior and inferior lumbar spinous processes of the desired interspace. Then local anesthesia is infiltrated 1 centimeter lateral to the midline and to the superior aspect of the inferior spinous process. So what is the direction of the needle? The needle should be directed 10 to 15 degrees medially. This paramedian approach is useful in case of deformed spine, arthritis, or in case of previous spinal surgery. Next slide, please. So in this diagram, there are midline approach and paramedian approach. So for paramedian, the site of entry is 1 centimeter lateral and 1 centimeter above to the inferior spinous processes. And the direction of needle is towards the midline. Next slide. So what are the advantages and disadvantages of disadvantages of midline approach? Advantages are in midline approach we get the larger target area to interlaminar space. There's a faster procedural time. There's a lower incidence of post-dural puncture headache and less chances of traumatic complications. Disadvantages are for the midline approach, the flexion of spine required, and it is difficult in obesity, spinal deformity, and fracture of the spine. There is a higher incidence of paresthesia. Next slide. Then what are the advantages and disadvantages of paramedian approach? Advantages are flexion of spine not required. There is a lower frequency of technical problems, higher success rate with paramedian approach, less number of attempts required, and there is a lesser incidence of paresthesia. Disadvantages are more chances of traumatic complications in paramedian approach, and it requires longer protrusion length of spinal needle. Next slide, sir. Third approach is Taylor's approach. It is a modified paramedian approach utilizing the larger interspace, that is L5, S1. The spinal needle is inserted 1 centimeter medially and 1 centimeter above the lowest prominence of posterior superior iliac spine. The needle is directed upwards, medially, and forwards at an angle of 50 degrees, as shown in this diagram. Taylor's approach is used in case of spinal fusion, arthritic spine, in opisthotonous position, in skin infection, and any surgery on the spine. Then we will see the recent advances. First, we will see the USG guided spinal anesthesia. So in USG guided spinal anesthesia, there is a pre-procedural scan and real-time USG guided spinal anesthesia. So in pre-procedural scan, we accurately locate the midline. We identify a given lumbar interspace and we predict the depth of epidural space. So it is USG guided spinal anesthesia used in case if there is obesity, edema, if there is any spinal deformity or any previous spinal surgery. Next slide. So in pre-procedure scan, we scan the spine of the patient in pre-operative area. We use a low frequency, that is 2 to 5 megahertz transducer. We place this transducer 2 centimeter lateral to the midline in a longitudinal paramedian orientation with a slight medial tilt. So we'll see the sawtooth pattern of lamini. As shown in the diagram, we see the sawtooth pattern of lamini. Then we identify the posterior longitudinal ligament. So ability to see the posterior longitudinal ligament indicates the unobstructed part to the dura. So there is one score, that is posterior longitudinal ligament score. The quality of the image of the posterior longitudinal ligament at each level, that is from L1 to L5, it is recorded as absent, hazy or clear with values of 0, 1 and 2 respectively based on clarity on both left and right side. So on left side, the total score is 8 from L1 to L5. And for on right side is also the score is 8. So total PLL score is 60. So as shown in this diagram, between L2 and L3, we cannot see the posterior longitudinal ligament. So here the PLL score is 0. And in between L3 and L4, we'll see the posterior longitudinal ligament, but it is not clear. So we will give the score of 1. So score of less than 8, we can predict the difficulty in giving spinal. Next slide, sir. Then we'll see the real-time USG guided spinal anesthesia. The position is sitting or lateral position. We'll use low frequency, that is 2 to 5 megahertz curved array probe. There are 5 basic USG views of the spine, 3 parasagittal plane and 2 in transverse plane. So views are parasagittal transverse process view, parasagittal articular process view, parasagittal oblique view, and 2 transverse spinous process view and transverse interlaminar view. Next slide. So we'll see these views one by one. First is a parasagittal transverse process view. Here the parasagittal plane is a few centimeters lateral to the midline. So here the probe is placed over the transverse processes. So here in this view, the transverse processes appear as a finger-like acoustic shadows separated by a striated sauce major muscle. So it looks like a trident. So in a parasagittal transverse process view, we see the trident sign. Next slide, sir. Second is a parasagittal articular process view. Here the probe is placed over the articular process. We slide the probe medially while maintaining the strictly parasagittal orientation. Then we'll see the transition from the discontinuous pattern of the transverse process view to the continuous pattern of or hyperechoic lines of articular process. So it looks like a camel hump. So in parasagittal articular process view, we'll see the camel hump sign. Next slide. Then third is a parasagittal oblique or interlaminar view. This is most common view. Here the probe is placed over the lower lumbar spine in a parasagittal orientation, a few centimeters lateral to the midline. Then we slowly tilt the probe 45 degrees towards the midline to direct the beam in a lateral to medial direction. Then we'll see this sawtooth pattern of lamini. The teeth correspond to the downsloping lamini, and the gaps between these lamini represent the interlaminar space. So this interlaminar space is bounded anteriorly by anterior complex and posteriorly by posterior complex. So anterior complex consists of anterior dura, posterior longitudinal ligament, and the posterior border of the vertebra. While the posterior complex consists of ligamentum flavum, posterior dura, and epidural space. Next slide. Then 2 transverse views, that is transverse spinous process view. First is transverse spinous process view. Here the probe is placed in a horizontal orientation with center of the probe placed over the midline. The probe is placed over the spinous process. So the tip of the spinous process appears as a superficial hyperechoic cap surmounting a tall, dense acoustic shadow. Next slide, sir. Second transverse view is a transverse interlaminar or interspinous view. Here the we turn the probe 90 degree into a transverse orientation and slide cephalad or caudal to obtain the transverse interlaminar view into chosen lumbar space. So here the probe is placed over the interlaminar space. The hypoechoic intrathecal space is bounded anteriorly and posteriorly by the parallel hyperechoic lines of anterior and posterior complexes. In this view, we'll see it looks like a bat's wing. So in transverse interlaminar or interspinous view, we'll see the bat's wing sign. Next slide, sir. So either you give spinal directly under the guidance of USG. The position as shown in this picture, the position is like this. The probe is held in one hand and the spinal needle is held in other hand. Then we first identify the sacrum as a hyperechoic line. Then we identify the L5 S1 interspace. Then we move the probe cephalad and we identify the other interspaces. By using a parasagittal oblique view, we identify the interlaminar space and we insert the needle under the guidance of USG. Next slide, sir. Or you can first mark the we make the skin markings for the needle insertion. So we can make the skin markings for midline approach and also for paramedian approach. For midline approach, we use two views: transverse interlaminar view and second is parasagittal oblique view. By transverse interlaminar view, we place the probe in transverse orientation. We make the skin marks at the midpoint of the probe's long edge corresponding to the neuraxial midline. And second, we mark the midpoint of the probe's short edge on both sides that corresponds to the interlaminar or interspinous space. So intersection of these two marks gives a needle insertion point for midline approach. And by parasagittal oblique view, we identify or mark the neuraxial midline, and then we identify and mark the intervertebral levels. So intersection of this mark with neuraxial midline indicates the point for needle insertion. Next slide. So in this diagram, there are both views, parasagittal oblique view and transverse view. So in parasagittal oblique view, first we mark the neuraxial midline, and then we mark the intrathecal space at the level of we mark the skin markings over the intrathecal space by parasagittal oblique view. The intersection of this point is the point for needle insertion. And in transverse view, we mark the neuraxial midline, that is midpoint of long edge of the probe and midpoint of the short edge of the probe. The intersection of this point is the point for needle insertion for midline approach. Next slide. Then skin markings for paramedian needle insertion. Here we use a transverse spinous process view. The probe is placed over the transverse over the spinous process. Then skin marks made at the midpoint of the long edge of the probe corresponding to the neuraxial midline. And second, we mark the skin at the midpoint of the short edge, which corresponds to the spinous process. So we mark the spine. We mark the midpoint of the short edge for two adjacent spinous processes. The needle insertion point is marked 1 centimeter lateral to the midline and 1 centimeter superior to the line indicating the lower spinous process. So needle inserted with a slight medial and cephalad angulation. Next slide. So in this diagram, there is a point of needle insertion. So first we mark the neuraxial midline, and then we mark the two adjacent spinous processes. So intersection, the point of entry is 1 centimeter lateral to the midline and 1 centimeter above the line indicating the inferior spinous process. And the direction of the needle is towards midline, medially. What are the advantages of USG guided spinal anesthesia? It is a non-invasive, safe, simple to use. It can be performed expeditiously at the point of care. It provides real-time images, and it is devoid of significant adverse effects. Disadvantages are it has a longer procedural time and with difficulty. Occasionally indicate the incorrect intervertebral space and one-handed manipulation of the spinal needle required. Next slide. Then second recent advance is C-arm guided spinal anesthesia. So what is the position? Same, the patient is in sitting position. Then we use the C-arm, lumbar spine observed from lateral view. The L3, L4 interspace is identified and we introduce the needle under the guidance of C-arm. So it is useful in obesity and spinal deformity. Next slide. So it is another recent advance used in difficult spinal anesthesia. What are the advantages? Accurate intervertebral interspace and neural paths in real time. We use both hands for needle manipulation, and C-arm machine is routinely available in orthopedic working. What are the disadvantages? Of course, there is a radiation exposure, and it is not recommended in pregnant patients. Next slide. So, what are the take-home message? Pre-operative assessment of spine to predict difficult spinal is must. Then always connect the monitor while giving spinal in sitting or lateral position. Watch for vasovagal. Give some local anesthesia before taking prick. Use USG ultrasound or C-arm in case of difficult spinal. And if G is not contraindicated, don't hesitate to switch to general anesthesia. Thank you.